Please, thanks, Maddie. Yes, so thank you everyone for joining our webinar today titled The Hows and Whys of Community Involvement in Evidence Synthesis. This is a Cochrane Health Systems and Public Health hosted webinar, so welcome. I'd just like to start by acknowledging the traditional owners of the land we're meeting on today, the Awabakal people, and pay my respects to elders past, present and emerging. We have two awesome speakers for you today, Louisa Walsh and Rebecca Ryan. So I'll just give you a brief introduction on Louisa first. Dr. Louisa Walsh is a physiotherapist, tertiary educator, and public health researcher with research interests including participatory methods, evidence synthesis, health service and system design, and digital health.
All right.
Louisa is passionate about involving consumers and other stakeholders in health research and health service and systems designed to ensure that health research and services meet the needs of people and communities who use and work within them. Louisa is a senior lecturer in the Department of Health at Swinburne University of Technology and holds an honorary senior research fellow position at the Centre for Health Communication and Participation at Trobe University and the Burnet Institute. So thank you, Louisa, for agreeing to present for us today. And Louisa is also presenting with Rebecca. So Dr. Rebecca Ryan has a background in pharmacology and neuroscience and is a leader in evidence synthesis and health communication. She has been a research fellow with the Cochrane Consumer and Communication Review Group since 2004. And became the editor in 2011, and now has served as Cochrane coordinating editor since 2019. In these roles, she writes and edits Cochrane reviews and develops guidance to support authors in producing rigorous, high-quality evidence synthesis. Rebecca is also head of the Centre for Health Communication and Participation. Her research focuses on advancing methods of research, evidence synthesis, particularly in the fields of health communications. So again, thank you, Rebecca, for joining us. Love hearing your talks. Just a little housekeeping as well. If everyone could just please keep their microphone and cameras off for the duration, that'd be great just for bandwidth. And if you have any questions, please just pop them in the chat and we'll have some time for questions at the end. I'll now hand over to you guys. Thank you. And yes, chats at the end.
Thanks so much, Sam. I'll just share my screen. Thank you so much for having us along to present on something that is really, I guess, a passion of ours and a long-standing part of our research practice. And I hope that I can convince everybody else that involving different community members in your evidence synthesis project is really worthwhile and actually kind of fun. And if you saw my post on LinkedIn, I think this is an area of community involvement that people are still getting their heads around a little bit, because sometimes people think that evidence synthesis projects are just highly technical and maybe a little bit too boring. But hopefully it's not just the nerd in me, but that I can convince you that this is a good thing to do and good for both researchers and community members. So I would also like to acknowledge the traditional custodians of the lands that I'm coming from. And I'm currently on the lands of the Wurundjeri people of the Kulin Nation down here in the outskirts of Naarm, so in Victoria. I'd like to pay my respects to the Aboriginal people who are the custodians of these lands. And I particularly want to acknowledge any Aboriginal and Torres Strait Islander people who are joining us for this session today or listening to the recording afterwards. I'd also like to pay my respects to elders past and present. And if you're on country that has traditional custodians, then please pop where you are and the custodians of the lands that you're on in the chat. This is a picture taken near my house of the Merry Creek. And the Merry Creek was originally called the Merry, and that means very rocky in the Woiwurrung language of the Wurundjeri people from this area. But from this picture, you can't necessarily tell that this is a very, very rocky creek and lives up to its name. So just a tiny bit about the Centre for Health Communication and Participation. So we are a small research centre at Trobe University. I obviously now hold an honorary position at the centre, but I worked there for about 8 years and I did my PhD there as one of my primary places of work. And Rebecca still works and heads up the centre. So we really aim to improve health communication with and participation by consumers and carers by working to promote evidence-informed policy and decision-making that includes the voices of people with lived experience of health services and systems. So we are a very small team located through La Trobe University, and most of us work in an honorary capacity for the centre now. Our website is still live and all of our research is available through the website, so please check it out. And we have that long-standing association with Cochrane as the Cochrane Consumers and Communication Group, and now as part of the People, Health Systems and Public Health thematic group. So evidence synthesis is a large part of the research that we do through the centre, and we also do primary research projects as well. Do a lot of work around better development of health information and communication outputs for different government agencies. And so that's really been a lot of the focus of our work. So today I'm going to be going through just some overview of involvement principles, so involvement in research. So what do we mean by involvement and why should we involve community members in the research that we do? How you can use the research stages and levels of involvement to plan for community involvement and the facilitators and challenges of community involvement in research. And then I'm really going to drill down into involving community members in evidence synthesis and present a range of different approaches based on some case study research that we were involved in and did a few years ago, but have elements that are continuing on to this day. And then I'll finish off the presentation with just going through some key lessons. So the first thing that I would like to involve is that there's a lot of terminology that exists in this space. So you'll hear a lot of different words, and it's really easy to get hung up on these words. So you'll hear words like involvement, partnership, engagement, participation. And I don't really want to spend a lot of time on terminology because we do kind of get bogged down in the terminology a little bit. And these sort of discussions can take a lot of time. So I really want to go to today, for the purpose of today, these are the types of definitions that I'm using. But you might also find that I shift my language as well because there are so many different conflicting terms in this space. So when I'm talking about community, I'm talking about people who are affected by the issue that's under study. So that's being studied through the research. And we often define community through common characteristics, such as people with a shared health condition, shared experiences, in our case of the health system, shared geography, so it might be a place-based community. And community can be quite narrow or it can be quite broad, again, depending on the type of research that you're doing and the people who are most affected by that research. I think the key thing is that you need to define who this community is for every project that you do. So different projects will have different community members who might be appropriate for being involved in the research. When I talk about involvement, I'm talking about a bi-directional relationship between stakeholders or community members and the researchers, which results in informed decision-making about the selection, conduct, and use of research. So hopefully through that definition, you can see that it's not about research participants. We're not talking about people who are like participants in primary research, people who are under study, but it's a more equitable relationship where there is give and take between both broad groups of people, and that there are benefits for the people involved in that relationship on both sides. It's much more a co-researcher relationship than a researcher-participant relationship. So that's the difference that we're talking about. Community involvement in research includes a really broad range of activities and methods. And as I said, it's different to being a research participant. So that's not what we're talking about today. So when we think about the whys and why involve community in research, there are some really good whys. So when we look at the research around community involvement in research, we find that the reasons to do it are that there is an increased likelihood that the research will meet the stakeholder needs and interests. So there's increased likelihood that your research will be used by the people who are affected by the research, that it will be looking at the right questions and the right elements of their experience to, for example, to make real change in the health system than if researchers didn't involve community members as co-researchers in their projects. It can make aspects of the research more robust by talking to people who are directly involved or affected by the issue. So again, as researchers, when we involve community members in our research as co-researchers, we don't have to guess about the things that are most important to them. We don't have to guess about the things that are affecting them. We don't have to guess about the key questions we should ask for our research. And then also it can help with some of the methods down the track in terms of recruitment, data collection, data analysis as well. So it can strengthen our methods. It might be a requirement of some funders or academic publishers, and we're seeing that more and more, that grants through things like the NHMRC and the MRFF, either through targeted grant rounds or just generally, are looking for evidence of community involvement in research to strengthen the justification for the research that's going to be funded. Similarly, we're seeing some journals want people to make statements about community involvement in their research, and it can increase the likelihood of publication. Involving community members can actually increase the researcher's motivation and enjoyment. And this is where I get to, I enjoy working with community members in research projects. I find it motivating, I find it fun, I find it a good way to grow research skills beyond the academy, beyond universities, and grow the skills of people out in the community. It can increase feelings of enjoyment, pride, and confidence that comes with learning new skills and knowledge. And that's both the researchers and the community members. So both parties can actually feel their skills and experience growing through working together. And then if we think about concepts of nothing about us without us or democratization of research, that providing opportunities for community members to be part of research projects, to influence how research rolls out, what types of research is done, is really upholding those principles of, particularly for people from different health communities, disability communities, or other marginalised groups. It gives people a chance to really shape what is being explored about their experience, or targeting improvements in things like health services, without, again, us as researchers sitting in a kind of paternalistic view and making decisions on behalf of community groups. So thinking through some of the practicalities, I like to go back to, it's kind of getting a little bit old now, but this article from Shippey is a really great one to go back and have a look at, because it really lays out the stages of research and how communities might be involved in different research stages. Now, this is getting a little bit old now, and I'm sure that a lot of other researchers have come up with different, more creative ways at each of these research stages to involve people in their research. So I imagine that this sort of box at the bottom is only growing as with ideas as more and more people involve community members in their research. But you can see from this diagram that Shippey really advocates and has mapped out consumer involvement at every single stage of the research. what I really want to point out here is that people from the community can be involved right from the outset, right from setting the research agenda and seeking funding. Now, if you're new to consumer involvement in research, that can be a little bit hard to do because you don't have the connections and the partnerships and the relationships to be able to draw on people that early in your research process. But the earlier that you can involve people, the more that you're shaping your research around the consumer and the community wants and needs, and the more that people can influence how the rest of the research rolls out. But even if you can't involve people right at that early stage, you can see that there's great ways all along the research process to involve community members as co-researchers. Now, some of you or many of you might be familiar with this diagram. It's from the IAP2. The other thing that I like to think about when planning for community involvement in research is thinking through level of involvement. So when I talk about level of involvement, what that means is the degree to which community members who are co-researchers in the project have the power to influence or make decisions. So that's what we really mean in this diagram about level of involvement, how much they can make changes or influence changes to the project. So remember, the aim of involving community members in your work is to help the research team make informed decisions about how the research is undertaken. So you really need to think critically and honestly about how much power your stakeholders or community members have to define the research project or change the things you have planned. The more power that someone has to change your plans or to define the research agenda, the higher up they are in this spectrum of involvement. So these are the different types of models, both thinking about stage and level of involvement, that you could use when you're thinking through how community members might be involved as co-researchers. And after this presentation, I'll put together some key resources. There's a comprehensive reference list at the end of the slides, and you'll receive the slides. But I'm very happy to put together a list of key resources from that reference list that I find very helpful when thinking about community involvement in research. So in terms of what works, so this is a key question that people ask about, okay, that's all well and good, but how do we actually do this? So this is the hows. So tailoring involvement approaches to meet stakeholder and research needs is critically important. So there's no just one size fits all. There's no gold standard of involvement. It's really down to what the project needs and what the community members and the researchers are capable of delivering. Training for all community members and researchers involved. I think sometimes we focus on the training needs or the upskilling needs of the community members involved as co-researchers and assume that the researchers have the knowledge inherent to them. But actually, for people who are new to community involvement, this is new for the research teams as well. And so sessions like this and other training is critically important for the researchers as well, because we're all learning together. We need systems that support community member involvement in research. And so some of the barriers that people often face, people like me who are currently working in universities that are very bureaucratic, sometimes community involvement as co-researchers is difficult for ethics committees to get their heads around because they're used to working in a kind of paradigm or environment where community members are research participants, not co-researchers. Thankfully, this is getting easier as ethics committees get more familiar with participatory methods like co-design and co-creation. I think that this as a barrier is getting less, but it can still be difficult for ethics committees to kind of understand, the consumer involvement, whether it even requires ethical clearance, the type of ethical clearance, the risks involved. Those things can sometimes be hard for ethics committees to get their heads around, particularly if not a lot of these projects are happening in their environment. Similarly, there's always the kind of thorny issue or difficult issue of remuneration. And so from a practical standpoint, sometimes the bureaucratic blocks within organisations can actually make it hard to pay people who are involved as community members on research projects. And then there's also some just questions about how much is enough, and guidance around that is not standardised. It's not standardised within organisations. It's not standardised across the country. So it's always something that needs to be sort of worked through in a project. And then also we know that making stakeholder involvement a requirement of research funding or publication, so those drivers that I spoke about before, are actually effective in making that more part of the research culture. So as more funders or publishers demand that that's part of people's research practice, then we see, that there is a natural flow and effect that people start doing it more. Providing practical assistance to community members to help overcome barriers. So identifying what the barriers to participation are or involvement are, and working through those and aiming to overcome them where they can be overcome. So that can be including payment for involvement, addressing accessibility barriers, ensuring activities are culturally appropriate and safe, things like trauma-informed practice where you're a researcher. These things can be practical strategies to overcome barriers that people face to being involved in as co-researchers in projects. Matching stakeholders interested in the research to their areas of interest and expertise. This feels like a bit of a no-brainer, but if someone's not interested in a project, then why would they get involved as a community member? And it's sort of the same as researchers, right? We don't want to research something, or we're more reluctant to continue on with a long-term project if we're not actually very interested in the topic. So matching people to what they're interested in can really help with sustainability of a project. This one should really be at the start of my list, which is actually involving the community members in planning how they'll be involved in the research. So asking people what things they would like to do, what elements they would like to be involved in, which stages of the research they're interested in, that really helps with engaging people. And then having a really clear purpose of community involvement and clear timelines and expectations of a research project. People are much more likely to get involved, even if it's a long-term project, if they know that this is what they should expect along the way, this is how often that meetings are going to be, this is when we should expect to be finished. So having those in place is really useful too. So some of the challenges, because there are challenges undeniably, is knowing who and how to recruit. So actually, how do you reach people who might be interested in being involved in your research? There can be struggles within groups with conflict, reaching consensus, and just those general group and power dynamics that can exist in any project. We know that lack of time and other resources, including lack of funding, can be a real challenge to community involvement, particularly over the long term. And ensuring diverse representation. A lot of teams who are involving community members in research feel that they're just going back to the same people and that they're not able to find new people. As I've mentioned before, ethics processes can be a challenge too. And one of the challenges that we sometimes come up against is a lack of evidence of impact of stakeholder or community involvement in research. And what I mean by that is that we don't have a lot of what in research we call that kind of level 1 evidence, those systematic reviews of the effects of interventions that Cochrane, we love so much at Cochrane, that say that involving community members makes these outcomes of research projects change. And that's because it's really hard to do that research, because it's hard to run a thing like a randomized controlled trial on community involvement in research. So sometimes this lack of intervention evidence is held up as a reason not to do community involvement. But we have a lot of other ways that tell us, and other pieces of research that tell us that there are some real benefits to involving community members. And actually, overarching all of that is that kind of moral argument for community involvement around the democratisation of research and the nothing about us without us, is that community members should be a part of the research that is done with on to them. And so even though we might not have the evidence that says community involvement will change X, Y, Z outcomes of your research, there are a lot of other really good arguments to do it. And we also have to address that there are potential harms associated with involvement. So people can experience feelings of being devalued, particularly in projects where their involvement is tokenistic. So they're just there as a ticker box exercise, or they're not listened to. And we know that particularly in health, because we're often involving people in our research who have had negative experiences with health systems or a lot of contact with health systems, and we're often asking them questions about that are related to their health conditions or their experiences in health systems, that there is that risk of traumatization or re-traumatization of people because they're having to tell their story over and over and over again. So I want us to be cognizant of the fact that there are potential harms associated with involvement and that we need to address those. So in this slide, I've just taken that diagram from Shippey and I've just modified it. So when Shippey did their research, their review into consumer involvement, they were looking at primary studies. So they weren't looking at evidence synthesis studies. So in this slide, I've just subtly changed it with some very rough boxes to just show that a lot of the Shippey kind of recommendations of how people can be involved and ideas for how they can be involved still apply when we're talking about secondary research. So when we're talking about systematic reviews, scoping reviews, qualitative evidence synthesis, those types of projects, these same ideas still apply. It's just that things like our study design and procedures and our data collection and processes and recruitment or inclusion-exclusion processes, we just kind of call them different things because we're not dealing with people, we're dealing with published studies. So these are just some ideas about how people can get involved at these different stages related to evidence synthesis rather than primary research. All right, so for the rest of this session, I'm just going to go into some case studies to give you some really concrete examples of consumer involvement in evidence synthesis projects. Because I think without some concrete examples, it can be a little bit difficult if you've never done this work before to kind of think through how you might involve community members as co-researchers. So all of these case studies I'm taking from this journal article that I was a co-author on, which is around lessons from Cochrane's Public Health and Health Systems Network on stakeholder involvement in systematic reviews. This work this paper was led by Bronwyn Myrna, who has a lot of experience in this space, and I really want to acknowledge her as the author of this and also the lead on a couple of the projects that I'm going to talk you through. So I was involved as a co-author, but she was the lead and wasn't available for today's presentation. I'll link to this article in the sort of list of resources that I'm going to send around after this presentation. So the first case study is one of ours from Cochrane Consumers and Communication Review Group. And it was a priority setting exercise that we did to determine which reviews we should sort of put out for authors to choose as priorities to publish through Cochrane Consumers and Communication. And so we really wanted to do this, really to put our money where our mouth is and provide opportunities for community members and a range of other stakeholders to influence our work and influence our prioritisation of reviews. So we ran this priority setting activity that started off with an 11-member stakeholder steering group who determined the methods of the priority setting exercise. And that stakeholder group included consumer and community members as part of that group. So setting the methods. So right from the start, people were involved, non-researchers or consumer crew researchers were involved in this project. Then we ran an online survey which determined a range of research priorities. And again, that went out to a broad group of stakeholders, which again included community members. And so 151 people from around the world participated in that survey to propose a range of different consumer and communication reviews that we should tackle. We then held a face-to-face workshop in Melbourne, which was taking those research priorities that had been identified through the survey and refining them down to review questions. And again, we had a large consumer contingent, community member contingent involved in those face-to-face workshops. So 28 people were involved, and I think about half of them were community members. And then when people proposed that they would, and then the final stage was that the research group then took those prioritised questions and had a look at what was already published through Cochrane and to see if any of those had been answered. And through that process, they identified 5 unanswered priority review questions. And then when we put those out, author teams would come to us and would say that they would tackle one of those 5 questions. So what happened through that process is that after that initial priority setting activity, we had 4 of the 5 priority reviews completed and published in the Cochrane Library. And the Cochrane review topics that were selected were improving communication about end-of-life care, patient and family involvement in patient safety interventions, improving future doctors' communication skills, and promoting patient-centred care. So you can see that it was quite a diverse range of proposed priority reviews within the kind of remit of Cochrane Consumers and Communication. And we were able to publish those 4 reviews in the years following this priority setting exercise. Now, I'm just going to pause for a moment here and throw to Rebecca, who was also involved in that project, and see if she wants to add anything to what I've said about that case study.
Thanks very much, Louisa. I think the only thing that I would add is that, which you've already referred to in part, is that because the scope of the kinds of evidence that our group was interested in is so very broad, this kind of priority setting was especially useful for us, I think, to really come to grips with what was going to be most useful to users of evidence or community members or patients, rather than us as researchers just guessing. And so that's why we felt it was really useful to undertake such a big priority setting exercise, because obviously you can't do every review that needs to be done because they're big pieces of work and they take time. So really, I think trying to focus our energies where they were most needed and wanted was really important. And I think that made us all feel very positive about this whole process because we felt like we were putting our efforts in the right places after having sort of engaged with different people to find those priorities. Thanks, Louisa. I don't have anything else to add.
Thanks, Beck. I think that's a good reflection, which sort of speaks to what I was talking about before, which is actually this is quite an enjoyable process and it's motivating for the researchers involved. Because having that confirmation from community members and other stakeholders that these were the things that they wanted and you could move forward with confidence with them is really important and valuable. Okay, so the second case study from that American Journal of Public Health paper is around one of the projects that emerged out of the priority setting exercise, and that was our co-produced quality of evidence synthesis on best practice partnerships between health providers and consumers to improve patient-centred care in health services. So patient-centred care was an important priority review that came out, but even through the process of kind of undertaking the review and involvement with community members as co-researchers, the question kind of shaped up and changed and became a little bit different. And we actually, even though it's not covered here, we actually ended up doing both a qualitative, so a systematic review of interventions, and a qualitative evidence synthesis under this kind of banner of improving patient-centred care. But the focus of the review became around how consumer-provider partnerships, particularly in kind of advisory or committee scenarios, can help health services improve patient-centred care. So doing the QES itself, we had an 18-member stakeholder panel that again included about 50% consumer or community member co-researchers. There are a number of different stages. We had an initial meeting where people discussed potential topics for the review and voted. And this is where the decision was made to do a QES. But at Cochrane, they also wanted us to do a systematic review on a kind of related topic. So we ended up with these kind of paired review on this topic. And it's also at the first meeting that it was decided to focus in on this kind of consumer and clinician and other hospital stakeholder relationships within within committees to improve health service design and delivery. So in the second meeting, the aims of the review were bedded down and the selection criteria and the search strategy. So that was all very methodologically focused and really getting to the nuts and bolts of how the review will be done. At the third meeting, we were up to full text screening. So between meeting 2 and meeting 3, the search strategy was run, the title and abstract screening was done. But then at meeting 3, we brought back the title and abstract screening results and everybody was involved in full text screening. So this is where even some of those really practical components, technical components of doing evidence synthesis, we had community members involved in that process as well. And it was a good learning experience for us as researchers about how to communicate those processes. And we've developed up like a sort of screening criteria guide and some tools that people could use to make that screening process easier. And then for community members who hadn't done a lot of deep reading of journal articles before, it was a really interesting experience in terms of how you read an article with a view to including or excluding from a study. So the types of things you're looking at, learning about the different sections of the review. So really increasing their skills in research and evidence synthesis. And then at meeting 4, between meeting 3 and meeting 4, the research team had gone away, developed up some preliminary findings. And at meeting 4, we presented those findings and then determined that out of those findings, those preliminary findings, it would be good to construct a list of best practice principles that did end up appearing in the review. So it all gets a bit meta because we were doing community involvement and then we came up with these best practice principles for partnering with consumers as part of that process. And so each of these principles has associated practical strategies underneath them. And like I said before, I'll include these references in a reference list so you can go away and have a read of them. But the broad sort of areas that people need to think about when doing consumer engagement in health service design and delivery are things around leadership and health service culture that facilitates and encourages consumer engagement, engaging for diversity, ensuring equity in these groups, ensuring that these groups have a mutual respect, shared vision and regular communication, shared agendas and sharing decision-making together, the degree to which people can influence change, and also how to make these types of groups sustainable. So I'm not going to go into detail on each of those, but that's one of the products that has come out of that project. And then this work has continued on into a recent project around designing an implementation framework for the best practice principles. So again, continuing on that work, working with consumers to develop up the best practice principles. So now this is a project that's been going on. If you take into account the first case study, which was the priority setting exercise that then led to this review, this work has now been going on for about 10 years. So it's been a long-term project, and some of the consumers have remained the same and some have dropped away and others have come into the project. But this has been a long-term consumer involvement project and experience for our research centre. And Rebecca, I'm going to throw to you again. Is there anything that you wanted to add?
Nothing much, Louisa, other than I guess for me and probably for you as well, for all of us, I think we were learning as we went with this project. So it really has shown to me when I look back how important it was to have stakeholders involved, community members involved from the very beginning, because that completely changed the emphasis of the evidence synthesis that we did. I think if we were researchers, we would have just gone along and done a good old Cochrane intervention review. But as it was, the stakeholder group was so influential in not just sort of the focus of the review itself, so looking at partnerships rather than the very big area of patient-centered care, but that they were really, really decisive about the need for not another intervention review, but instead something that would help with the actual implementation or putting it into practice. So that's where the qualitative piece of work came from. And I think that to me is such a nice illustration that, as researchers, it's so easy to think we know this area really well, we know what's needed, we know this is a priority, but it really turned our work on its head, and that's had really long-lasting implications for the work that we've done and in the directions that it's taken. And it's been really lovely to have a lot of those people along at different stages for the ride and to see how this work is shaped. So it's been, I think we've all learned a lot from doing it, and it's made us feel again that it's much more relevant and that the work is, the effort and the time is worth putting in because it's something that's useful to different people. So thanks, Louisa.
Thanks. Okay, the final two case studies I'm just going to go through a bit quicker because they're not, we're not involved in these in the same way. So case study number 3 from that American Journal of Public Health paper is that there was stakeholder involvement in developing a WHO guideline. So that recommendations on digital interventions for health system strengthening. And the different ways that stakeholders and consumers were involved in this case study and this WHO guideline were that they determined which interventions would be included in the guideline and provided input into the guideline question. And then also were part of designing Cochrane reviews to develop the evidence to inform the guidelines. So where the evidence didn't already exist, there was a process of designing Cochrane reviews that involved the consumers in that as well. And similar to our priority setting exercise, there was a survey to help refine the questions as well, and that included community members. And they ended up at a qualitative evidence synthesis place too. So I think that also speaks to, that we think as researchers that our kind of level 1 evidence, our highest evidence is our intervention reviews. But actually, when we talk to people, they're quite interested, and maybe even more so, in qualitative evidence synthesis. So drawing together those experiences, as Beck said, to produce something that just doesn't say whether something's effective or not, but tells us the how of doing things. And so I think that was an interesting outcome from this case study. And then our final case study, I think, has consumers involved in a smaller way. And was around helping people use Cochrane review findings in practice. So they had consumers and community members involved in helping them develop German language summaries of Cochrane reviews and testing those summaries before they were disseminated out. And this group also used very targeted dissemination strategies through things like personalised emails and press releases to ensure that those German language summaries reached the people that they needed to reach. So if we're thinking back to levels of involvement, this is a little bit of a different way of thinking about that same IPA2 table, which uses slightly different language. But we've just laid out here the different projects, the different case studies, and how much influence the community members had over the research. So I'm not going to go through this in great detail, but you can see that our sort of Cochrane priority setting activity and the qualitative evidence synthesis kind of sat up at this leading or controlling end. And things like the dissemination review in case study 4 sort of sat more at this receiving end. So it doesn't mean that anything is better or worse, but it just means that these are the different levels that consumers were able to contribute to and influence the research in those different 4 case study examples. So I think the key lessons from the case studies are that, sorry, I just received a Teams call in the middle of that, so let me just get back into what I was saying about. So some key lessons from the case studies is that power imbalances within the groups of consumers and other representatives need to be proactively addressed. And that was a really big learning across the case studies, that you need to think about the differentials in power between the people who are in the room and who are involved. Also, that activities need to be adequately resourced, which we've talked about before, and that includes providing sufficient project time and expertise and budget. If you can't adequately resource a project, you're at risk of just tokenistically involving your consumers. Involvement of people at any stage is beneficial, but involvement early, when there's the greatest ability to shape the research, can be the most impactful. And I think that that's a good takeaway, but take it away with caution, because it's more challenging to involve people early if you don't have that history of involvement. So sometimes involving people early in a project is something to work up to through the duration of the project. So being flexible and having a willingness to change your approach is super important for genuine involvement, because if you're not flexible and you're not willing to change your approach, then you're going to limit the ability for your community members to influence your research. And also you need time for quality community involvement. It's not something that happens quickly or easily. You need training for both community members and research teams, and you need to ensure that research outputs are targeted and accessible. There are also really practical ways to address power imbalances, and we've drawn from the equity principle, from the best practice principles, to give you some ideas about how you could address power imbalances in your projects. So some of the things that we found through our research is that consumers are involved in recruiting new consumers for partnerships. So once you have consumers on board, or community members, they can be involved in developing the recruitment strategy. They can be involved in actually reaching out to people who might be appropriate. But that community members become either a point of contact or help you to devise your recruitment strategy or recruitment materials. There's an equitable proportion of community members to health providers in partnerships. So often we see projects where there's maybe only 1 or 2 community members and then 10 or 15 researchers. And that immediately sets up an issue with power and equity. So some people might prefer smaller, less formal meetings to be more comfortable, particularly when starting out on a new project or working for the first time as a consumer co-researcher. It can be less intimidating, less threatening. And when people learn their skills, they might then feel more confident to be involved in those bigger discussions. That consumers and community members have access to consumer-only meetings, and that they have access to peers, and information that supports their participation in partnering, so that the consumer members of your research team are given support both of peers, but also given access to data that can help them with their decision making, that they're not always just having to draw from their own experience. And that consumers are often offered ongoing training relating to their role. And that includes training around working in partnership and also the environment, so the health service environment or the research environment that they're working in. So just to summarise, so we have a little bit of time left for questions. Community members can be involved in any stage of an evidence synthesis project. And while it can be valuable to have people involved right from the start, that might be challenging if both the consumer members and the researchers are new to involving people. There's no one right way, and projects may use more than one method or level of stakeholder involvement, and that's usually the way that it goes. There's usually times when community members can be very influential in a project, and there might be times when they're not as involved. As researchers, we need to be flexible and accepting of changing ideas, approaches, and circumstances. And that speaks to making involvement genuine rather than tokenistic. Involvement activities need to be properly resourced, which is sometimes a struggle in the environments that we work in. And all parties can grow skills and experience in involvement over time and over projects. And I think one of the main takeaways here is that, we've shared these examples, these really great case study examples, but there is it's actually sometimes better to start small because it takes time to build up partnerships, to build up trust, to get to know the consumers who might be interested in being part of your project, to get involved with community groups who might be part of your project. And at the heart of it, this work is relational. And so if you don't have those relationships in place, then you're really going to struggle with recruitment. And so if you've never done this type of work before, then it is good to start small so you can develop those skills and experience over time. And you can work with consumers who can develop those skills and experience over time. And your approach doesn't need to be complex to be meaningful. And I think going back to those diagrams by Shippy, there's a number of different ways that you can think about involving people in your research. And if you're new to this, picking out a couple of those and working in a genuine way with community members as co-researchers in those aspects of your research is a really great starting point. So I know I haven't left heaps of time for questions, but I'm going to stop sharing my screen and happy to have questions. And I can see there's been some in the chat that I haven't been able to see. So I'm going to stop sharing, and I'll just as the thunder and lightning is starting at my place. And yeah, happy to answer questions anybody has in the last few minutes we have together.
Thanks, Louisa. Thanks, Rebecca. I'll just read out one from Dr. Joy Maridis. Sorry, Joy. Rebecca's already replied, but just Louisa, if you had any other thoughts on it. It's from a health systems perspective, is community engagement a moral imperative, a strategic tool, or both?
I think it's both. I think those from a health systems perspective, I think these things, though, can be in a little bit of conflict sometimes. Unfortunately, sometimes what we see is that funding and resourcing for consumer involvement is seen as less important than, ensuring day-to-day care of patients. And that might not necessarily be right or wrong, but when budgets get tight, the support for the practical support for consumer involvement and community involvement can go down in health systems. And so it still remains a moral imperative, but it becomes less of a strategic imperative when, the rubber hits the road of the reality of working in health systems. And look, I wish that that was resolved, because we also know that places that are doing consumer involvement really well are also not afraid to hold that up as a marker of the quality of their work. And it should create better work and better health services and systems. But yeah, I do wish that in the broader health services and health systems, that the rhetoric around the importance of consumer involvement, and in Australia it's part of our standard 2, it's part of hospital accreditation, was matched by the resourcing for it. So it could be done in a more genuine way in those environments. I think sometimes in research we're a little bit lucky that if we go down this road and we build it into grant applications and that sort of thing, then we have the funds available to do it well. Whereas I know that people working in health services, it can be a bit more of a cultural or economic or strategic decision about whether you're able to do it in a really genuine way.
Yes, yes. We might have time for one more question. So I wonder if you have any tips on how to incorporate the best practice principles when conducting rapid reviews.
Yeah, and Beck might be able to jump in on this one too, because I know she has more experience in doing rapid reviews. I think, from my point of view, obviously because of the speed of a rapid review, that if you don't have that in place and you don't have that experience already, and you don't have people who are like community members who already know you, work with you, know what it takes to do a review, that it's going to be very difficult to do a rapid review because by its nature, you don't have the time. I would say priority setting before you get to the point of your rapid review is a really good way to involve people early. And then if you have those good relationships and those people who already know how to do reviews and bring the community perspective to them, then that's an opportunity there. But I would say it'd be pretty difficult in a rapid review, particularly if you're looking at those ones that are like, 3 days, 7 days, 2 weeks, that kind of jazz. So Beck, I don't know if you want to add to that at all.
No, I think they're the points that I was going to make too, Louisa. I think having those sort of trusted relationships with people that you can already work with would be really, really important as a starting point. And then if the rapid reviews were not ultra rapid, but more of the order of a couple of months, maybe it would be possible, I think, to be pretty directed in how you might involve people. You might decide to involve them at very key decision points in doing the rapid review. So you could be quite pragmatic and keep the exercise small, but think about where it might be most important to involve them. So perhaps it would be upfront at refining the questions or the selection criteria, perhaps, and then maybe at the draft finding stage. But I think if you are really constrained when you're doing a rapid review, there's not a lot of time not a lot of thinking downtime to sort of consult. So I think you would have to be pretty pragmatic, I think would be my main advice there.
Yeah, super pragmatic. I think that comes down to, like, if we're talking about genuine involvement, we really do need to think about what the demands of the research are, because you also don't want to involve people in a tokenistic way. Like, it's not like, why are you involving people then if it's just to tick that box? It's actually more harmful to the people who are involved and to the relationships if you know that in this project it's just not going to be possible. Yeah.
Yeah, yes. I could say it's right on 12, so I'd just like to say thank you. The scope of your research is really interesting, and I know it definitely helped us all. We struggle a lot with consumer engagement, so I'll be re-listening. The recording of this will be available later on our corporate public health website too, so hopefully later in the week we'll get this up there for everyone to re-listen and learn some more. Thank you again, Louisa and Rebecca.
Great. Thanks for having us.
Thanks very much. Bye.
See ya.